right, good afternoon, everyone. Thank you for joining us today. It wraps up our RHC webinar series for this grant year. And we're wrapping on a really positive note and exciting note, expanding access, especially to specialty providers in our communities. And so Zach and Greg will be tag teaming this presentation. So we are a smaller group on the call. If you have any questions, you can unmute your lines or put something in the chat. We know many folks do catch our recordings. And so if you're watching this recording and have any questions at all, please feel free to reach out to me. With that said, I'll turn it over to you guys.
Thanks, Laura. This is Greg Wolf from Wintergreen. I'm joined today by my colleague, Zach Bozer, and he and I are going to tag team today's presentation. And I would echo Laura and the team at the OSU have built quite an online empire with their recorded webinars. So thank you for joining today. And if you want to access this recording, you can always do that through the channel that Laura maintains through her Flex program. I wanted to do a little bit of housekeeping and reminding at the beginning of this presentation, then indulge myself in a little bit of a tangent around a quality improvement project in Oklahoma for rural health clinics, and then Zach's going to talk about specialty care integration. If you do not already have it in your calendar, I want to strongly encourage you to attend the annual Rural Health Conference in Edmond. It really is one of the best conferences that we come across in the country, and we get to go to a bunch of statewide conferences like this. You've got a real good one in Oklahoma, and you don't want to miss out. And don't skimp on how many people you send. If you're a critical access hospital, it would be great if your CEO and CFO attended, as well as your QI director and then practice managers for sure. So please mark that on your calendars. Make sure you register for it, and we hope to see you there. Okay, real quick, an update and then offering of an olive branch to all the clinics in Oklahoma. We are currently working and wrapping up year 2 of what will be an ongoing quality improvement opportunity for all of the rural health clinics in Oregon. So this is not limited to just the critical access hospital owned or the provider-based rural health clinics, but instead this is available to all of the rural health clinics, including the independents in Oklahoma. And what we're doing is we're working on quality improvement programming. And so our focus is on a select set of quality measures. You'll see them off to the right here. And what we're doing is we're helping clinics focus on these disease conditions through a structured method of developing Plan, Do, Study, Act, or PDSA quality improvement projects. Much of that work is pre-done for you. I like to say it is sanctioned plagiarism because we've built out templates and project models for each of these conditions. And it's available to all the clinics. Now, right now we're working in these states, and you'll see that Oklahoma is green because they were one of the 4 original pilot states that worked on this, this project. And we have a handful of clinics in Oklahoma that are in year 2 working on their second condition and seeing really nice results for their communities and for their empaneled patient groups. So it's really gratifying, really exciting to see our initial pilot group continue with this work. We added another, I think, dozen or so clinics in year 2, and we just want to see that group grow because there's a lot of opportunity for clinics to learn from one another. And we've made it real easy for you in the sense that we build the templates for you. They're 100% customizable, but we build these out for you so you don't have to go through the guesswork or try to invent the projects to work on, but instead the templates are there for you to review and then activate. And then we have the technology that allows you to set them up and monitor and document them. And the document part's really important. I was just on a call earlier today with one of the practice managers of an Oklahoma rural health clinic, and I mentioned to her, when you use the Lake tools to support your quality improvement work, when you go through your survey or your annual update, or heaven forbid, Joint Commission shows up, all you got to do is go to Lake and press a button, and it will download a printable PDF of all of the quality improvement work you've been working on and the measures that you've been tracking. And it's a nice way of saying, I'm never going to be too afraid of the Joint Commission or the state surveyors, and for our annual survey check-in and quality improvement work that we do with our critical access hospital on a monthly basis, I never have to be too anxious that I'm behind the 8 ball, because I've got all of my data and my project work organized in the same place. And so I mentioned that because Laura and I really do want to grow the number of clinics in Oklahoma that are working together on the quality improvement projects. And that'll be something that you can, if you're not already part of it, that'll be something you can join. You'll hear more about how to sign up for that in the fall. And we're certainly going to cover that at the November annual conference. This is just an example of the kinds of tools that we make available through the process of the PDSA methodology for those disease conditions. So basically, if you feel like you're working in a clinic, you're a little bit isolated, you need to be working on quality improvement stuff, you're not 100% sure what the priorities ought to be, how to get started, how to build a team, blah, blah, blah. All of that stuff has been pre-built out for your review through the tools that were developed over the last 18 months or so. Then the last little piece is all clinics in Oklahoma have available comparative analytics through the POND program. Again, this is available to you at no cost, like the QI project. It's funded through Oklahoma's Office of Rural Health and OSU and the FLEX program. And this is just a smattering of the kinds of reports that you can download through POND. And then my last slide before I hand this off to Zach. I share this as a way of focusing on the third item. When clinics enter their data and they generate their reports, what we like to do is to set up a Zoom, whether it's 30 or 60 minutes. And we at Wintergreen and LilyPad, we'll actually review the reports and the benchmarks with you and have a conversation around what your priorities look like, what they need to be, and share some ideas. Think of it as a free mini consulting engagement that is low stress, low intensity. It's almost usually a fun, friendly conversation around what's going on in your clinics and what the data are revealing to us. And that's one of the things that we really like to do, is use the data to identify some things to work on, have a chat, offer some recommendations or next steps, and all of that's built into the process. So if you are a clinic in Oklahoma and you are not part of the QI project, please consider it. If you are part of the QI project, we'll invite you to continue for a year 2 or year 3. And then if you have not put in recently your data into the POND system, we encourage you to do that. If you have any questions about either one of those programs, you can always contact Laura, or you can contact me directly. This is Greg Wolf, and my contact information Laura has available to you as well. So with that, Zach, I am going to stop talking and ask you to grab control of the screen so you don't have to bark orders at me telling you to switch slides every 45 seconds.
Wonderful. So thank you for that introduction, Greg. So today's presentation on specialty integration, as a critical access hospital, we have a wide range of different opportunities to be expanding the access that we have to specialty services. Now, we'll talk a little bit about some of the different models that we have and are able to do that. But specifically, we have a model where we are employing specialists. We can look at having professional service agreements and have a contractual relationship with different specialty providers. Or we can have visiting clinics and we're leasing space to different specialists and they're kind of operating as their own entity. Additionally, with the advent of telemedicine and the technological advancements that we have and some of the different programs, that is becoming a medium which is much more heavily utilized for providing different specialty services via telemedicine, with the inability for providers to actually travel to the different communities in which we serve. So all these different options have, different pros and cons, things that we'll talk about today. Some of them have unique billing, they're reimbursed differently, and then there's different challenges and alignment opportunities as well with that. So today we'll focus on two main sections specific to specialty provider services. We will talk about operational considerations and then the financial considerations that come along with those as well. So first we'll talk about the operational considerations and really talk about the current landscape in the healthcare environment which we're operating in coming out of the COVID pandemic. So we have a lot of these different things off to the right that we've been struggling with over the past few years. We're all experiencing staffing shortages and provider shortages, trying to understand, how do we bring specialty providers into our communities? Maybe we don't have the demand for a full-time provider. How can we allow an opportunity to be able to have providers come into our community? Maybe we already have competition within our service area that, a big percentage of the market is already cornered by some other independent provider. How do we work with them and leverage the opportunity for our practices and be able to integrate some specialty services and create referrals to other hospital services with these providers? Certainly we've all experienced significant service disruptions, surgeries being shut down, all of those different factors. We've all experienced significant cost increases. I've yet to work with a hospital yet that said that their reimbursement is increasing faster than their costs are increasing. So that's a significant headwind which we're currently experiencing, and we need to continue to find ways to think creatively in how we can continue to grow reimbursement for the services that we're already providing. We've had significant policy and legislative changes as well over the last few years, starting in 2019 with site neutrality that really reduced the reimbursement for provider-based clinics and kind of ushered in the provider-based rural health clinic cost-based reimbursement mechanism. Then only a couple of years later to have that reimbursement methodology change as well. And now we're kind of looking for, what is going to be coming down the pipe next. We've had significant out-migration and competition coming into the areas in which, we're providing services, and how do we deal with that? And we have some of the big tech companies getting involved in healthcare and things that we have to deal with and try to navigate as well. And additionally, revenue cycle issues. I've yet to work with a hospital and clinic that truly have all of their revenue cycle ducks in a row. And we're, consistently finding providers not speaking with coding staff, and we're undercoding, and we're missing charges, and all these different types of things that are creating a negative drag on reimbursement for our hospitals and for our clinics. So these are things that, are affecting us, have affected us, and that we need to continue to think outside the box and take a proactive approach to address these changes. And specialty integration is one of the ways that we can do that. So we've shared this slide through many presentations that we put on, but I think it's really, important to kind of show what is the overall performance model and what is the goal here, and providing the value that our services are going to put out into the communities in which we serve. And how do we go about doing that? So two main ways: looking at strategy and knowing that we're trying to craft a way to expand access to services and care for as many patients within service areas that we're currently operating. Many of us have done this successfully through primary care and rural health clinics, but also, can we take the next step now and begin integrating specialty practices within those rural health clinics? And we'll talk about this a little bit later, with the federal distance criteria for critical access hospital changes, are we now eligible to operate provider-based clinics in areas that maybe we weren't able to do that? So it's all about crafting the strategy for us to be able to grow and navigate those challenges and barriers that we were discussing on the previous page. Now, how do we execute on that strategy? And that's going to come down to the operations. And there's two main aspects there. So historically, we've had this divergence between, siloization between finance and quality. And we have our, performance improvement meetings for our quality. We have our revenue cycle and budget meetings for finance, and we rarely talk or seem to be working on goals that are aligned for the betterment of our organization as a whole. And with value-based programs coming down the line and new reimbursement models, they're kind of forcing the convergence of finance and quality, knowing that our reimbursement, is beginning to and will continue to be tied to quality and patient satisfaction and all those different types of things. So it's really important that we are breaking down those silos between finance and quality and coming together and working toward common goals, measuring metrics, and trying to push internal policies and initiatives that are going to align both quality and finance. Now, additionally, on the finance side, we have that broken down by revenue and expense. And as a critical access hospital, the majority of our costs are fixed cost. I'd say upwards of 90% of those are fixed. And we're often operating at minimum staffing levels. And so we need to find a way to continue to grow revenue and increase volume. Even as a critical access hospital, it's important for us to be focusing on growing volume and revenue, and managing expense is not the way that we're going to be able to cut our way to sustainability. Especially we're already operating for the most part at bare bones staffing and minimum staffing levels. And so there's no way to cut staffing, which is by far our greatest operating expense. And so we then need to focus on revenue. And how do we grow our revenue and services, and specialty integration is one of those ways that we can do that. So we'll start off with some definitions. In critical access hospital, I don't need to explain this too terribly much, but it's a federal designation under the Rural Hospital Flexibility Program, and a grant program that is funding this webinar as well. And so as a critical access hospital, we're eligible for reimbursement from Medicare and some states Medicaid because from cost-based payers, because we operate in service areas that have a really high prevalence and concentration of elderly and those that are more financially impoverished. And so the system was set up to help from a reimbursement perspective, knowing that we're going to be caring for more of those type of patients. I think the biggest thing that I want to point out on this slide is around the federal distance criteria and the clinic, the provider-based clinic as well, is that, up until this past year, the primary road definition was we needed to be at least 35 miles away on primary roads from the next critical access hospital or acute care hospital, and 15 miles on secondary roads. That recently changed, where any U.S., federal, and state highway it was initially one lane in either direction. As long as it was numbered and had the U.S. highway shield and all that type of stuff, that was considered a primary road. That was changed in November of last year, where a primary road meeting that same criteria needed to be 2 lanes in either direction now. So that opened up a lot of what I'll call secondary roads and gives us the opportunity to open additional provider-based clinics where we're not going to be busting our critical access hospital distance criteria, and it's going to create more opportunities for integrating specialty within those practices. So the definition that required CAHs that operate off-campus provider-based clinics, except for rural health clinics, again, RHCs are exempt from this legislation, that they must meet that federal distance criteria. And those that are on campus, those are included and grandfathered into that process. And the campus is defined as within 250 yards of the main building of our facility. And so again, this is something that's kind of opened up for us in the past year, where we can now think about where we may have been excluded from a distance perspective, that if we're 40 miles from the next hospital, we only had, 5 miles or so to play with trying to create a provider-based clinic, where if our road designation has changed, maybe we have more leeway to kind of expand the clinic footprint that we're able to provide for provider-based clinics, knowing that they're not limited to the 51% primary care as a rural health clinic. So this is an opportunity for us that really has opened up in the past year. So again, as I mentioned, we're generally a really high fixed cost entity. Healthcare is a very high fixed labor and capital intensive industry. And the majority of our costs are fixed, upwards of 90%. And so it's important for us to continue to drive volume for our organization, whether we're a critical access hospital, we're a rural health clinic, or a provider-based clinic offering different specialty services. Even with the legislative change for rural health clinics, gone are the days are the cost-based reimbursement. We're really operating on a fee-for-service model now. And so it's important for us to try to limit expense growth and creep, but make sure that we're driving additional volume to our services and reducing our per unit cost to the extent possible. Now, we know that as a critical access hospital, even if we're 100% cost-based, that's never going to allow us to really generate a profit. We're only going to be replacing our costs. And that's not going to allow us to invest in additional services and try to expand, telemedicine or specialty services, anything like that. So we need to find ways for us to be able to grow our volume, which will help reduce the fixed costs that are dilute those fixed costs at a faster rate than our variable costs are going to be growing. And this is going to create efficiency and reduce our per unit cost. And it's, if we think about this, that whatever our per unit cost is from a cost-based payer, we must reduce that per unit cost of each unit of service to a level below that of our commercial payers in order for us to actually generate profit up there in that right-hand corner. That is without any additional, other operating or non-operating revenues and 340B and all that type of stuff. So obviously the economic imperative is to continue to drive volume, act just like any PPS hospital that's reimbursed on, fee-for-service basis, knowing that we want to reduce and drive down our per unit cost below that of commercial payers where we can generate profit. So next, getting into the provider-based clinic. This is a clinic that is operated as a department of the main provider. So our critical access hospital, our financial operations must be integrated within the same EHR system, or if a different EHR system have interfaces that, all the financials roll up and the medical records are, kind of transferred in, and we're able to crosswalk between different systems. We need to hold out to the public and payers as a department of the main provider. We must meet that federal distance criteria, as I mentioned. So this is one thing that certainly has reduced or at least limited the growth of provider-based clinics at critical access hospitals in recent years. And it needs to be completely owned by the main provider. Now, some of the benefits here is that we're able to receive, especially for on-campus, within the 250 yards of the main facility, to receive increased reimbursement from Medicare and Medicaid as compared to, a freestanding clinic. Certainly, as I mentioned earlier, in 2019, site neutrality went into effect. So all those APC payments for off-campus clinics went away, where Medicare said, just because you operate a provider-based clinic off-campus, we're not going to pay you the same as a provider-based clinic that is on campus. And we're going to reduce that to the same reimbursement as a freestanding clinic. Now, one of the other benefits of a provider-based clinic is that they're eligible to participate in the 340B drug pricing program. As a critical access hospital, we're automatically eligible to participate in 340B. And so all the clinics that we operate are also eligible to participate in 340B. Additionally, these practices, provider-based clinic receives a facility and a professional component from Medicare, and that can also include the Method 2 election. So as a critical access hospital, Medicare is going to pay us a facility component or technical component that is a cost-based payment. And on the professional side, if we do elect Method 2, where we're combining or consolidating our professional and technical claims, that they're going to give us an extra kicker on the Medicare physician fee schedule on the professional side. So this is something that, again, we can utilize and leverage to an extent that we weren't able to do that without the distance criteria change last year, that will maybe allow us to, increase the provider-based clinic footprint around our facility. We're not subject to the primary care aspects of a rural health clinic, or, again, we can also look at integrating specialty practices within a rural health clinic as well, which we'll get into next. So again, a rural health clinic is located in a rural, medically underserved area, and it has its own unique reimbursement structure paid at an all-inclusive rate. One of the things that has changed or is going to potentially cause an issue with future rural health clinic designations is that in the 2020 census, the Census Bureau removed the definition of an urbanized area, which was one of the factors that a rural health clinic needed to be in an area that was not considered an urbanized area. And so, And so that's something that I think CMS is still kind of pondering at the moment to kind of understand how that is going to impact things, but it's something that we at least need to be aware of. We need to employ an advanced practice provider, whether this is a PA, a certified nurse midwife, or a nurse practitioner, at least 50% of the time that we're open to see patients. So if we're open for 40 hours a week, we need to at least 20 hours of advanced practice provider time. And as I mentioned earlier, that we need to be engaged in the business of primary care at least 50% of the time that the practice is open. So unlike a provider-based clinic where we could have, just a cardiology specialty clinic, this is something where we need to take into consideration the percentage of time that the clinic is open and what percentage of that time is operated as specialty clinics versus primary care clinics. Again, as I mentioned, the reimbursement has changed with the Consolidated Appropriations Act, the end of 2020, and starting in April 1st, 2021, that all new rural health clinics established after that time will be reimbursed at either based on cost with an upper payment limit set that started at $100 in 2021, and that's going to trend upwards of $13 per year up to $190 in 2028. Now, following the 2028, once we get to $190, that rate will be increased by the Medicare Economic Index for primary care, which I will talk about in a few slides from now, and that any rural health clinics that had been in existence prior to the legislative change are considered grandfathered, where their payment rate is dictated based on the fiscal year 2020 cost report, and reimbursement is trended upward also by that Medicare Economic Index for primary care services going forward. A provider-based RHC a rural health clinic that's a provider-based rural health clinic is one that meets the provider-based entity definitions. Again, must be 100% owned by the main provider. All of the financial operations need to be integrated within the financial system, need to hold out to the public and payers as a department of the main provider. One of the things, though, since the legislative change is that there's no longer that financial benefit for Medicare. Gone are the days of being able to load up, multiple, specialty providers and all this cost, that we allocate through the cost report down to our rural health clinic to get a cost-based payment. So we don't need to designate our rural health clinics as provider-based anymore. And that's something that we need to take into consideration. If we decide to establish a rural health clinic today, we're going to get paid the same reimbursement, as, an independent rural health clinic. But while we're making that determination, one of the things we need to take into account is, one, the Medicaid reimbursement, as well as the 340B impact to that clinic as well, because an independent rural health clinic is not going to be, able to participate in the 340B program, where a provider-based rural health clinic underneath our critical access hospital will be eligible for 340B. Next is the freestanding clinic. If we have an option, this is the one that we don't want to be. There's certain benefits to it. From a reimbursement perspective, this is the worst one, and the one that we would prefer not to be. This clinic is not operated as a department of the main provider. It's not subject to the distance criteria, so we can operate this clinic anywhere. We don't need to staff it with an advanced practice provider the way that a rural health clinic does. From a reimbursement perspective, there's no all-inclusive rate. It's not eligible for the 340B program, and it needs to bill under the Medicare physician fee schedule. Another drawback to this clinic designation is that it's not a cost-based department of a critical access hospital. So what happens is that this is considered a non-cost-based department or non-reimbursable. You'll see on your cost report, and that when we allocate square footage and other costs to this department, that overhead gets siphoned away from other cost-based departments and allocated to this non-reimbursable department. That's going to lower the reimbursement that we have for other cost-based departments. So all of those square footage departments, such as capital cost, plant ops, and maintenance, housekeeping, all those different types of things are going to pull overhead away from other departments in our hospital to this department, and we don't get any cost-based benefit for that. Next, we'll talk a little bit about the different provider relationships that we can have. So, first off is an employed model where we employ the specialty provider, and that we will also be billing on behalf of that provider for those services. One of the things that we need to take into consideration that on an annual basis, we need to make sure that compensation meets fair market value. We can, should be including a base salary. We should have a productivity mechanism, maybe it's work RVUs, and then some of the other incentive comp metrics that we think are best practice and we're starting to see are things such as patient satisfaction and panel size, other quality metrics. Again, as we continue to shift to the point where reimbursement is tied based upon quality and patient satisfaction, those are things that we should be incorporating within our provider agreements as well. Additionally, we want to make sure that we're abiding by all the Stark and anti-kickback statutes as well. Next is the professional services agreement. So again, this is a provider that's not employed by the clinic and the hospital, but we're creating a legal contract with the specialty provider or providers that they're delivering services for us. So this is something that also must compensate those providers based upon fair market value. And depending upon the type of professional services agreement that we establish, the provider or providers may reassign their billing rates to the critical access hospital. Certainly, this will have a more advantageous reimbursement impact. So this is something that as we're looking to establish these type of agreements that we want to take into consideration. Lastly is just a straight rental of space. We have a clinic space in our hospital that we can allow a provider to come and hang their own shingle and lease space from the hospital to the specialty provider, and that they're then going to operate as their own independent entity. So this is one that has the least benefit to the hospital per se, but it is allowing us to have that specialty provider in the service area, within the hospital, that it won't benefit us directly outside of rental space from a financial perspective. But, if patients are going to see that specialty provider and the patient needs labs drawn, or they need imaging or any of those other ancillary services, that the provider may refer patients to the hospital for those services as well. And again, as I mentioned, that anytime we have this scenario, this is where on our cost report, we're going to have those physician private offices where we're allocating square footage and other overhead costs to that non-reimbursable department. So again, all of these have, starting at the top, we kind of have more control, then lesser control, and then lesser control. There's from a reimbursement perspective, there's, less control and less opportunity as we go down through the spectrum here. but there's certain pros and cons that, maybe we don't have in the rental space. Maybe we don't have the need and the patient demand for, to be able to hire somebody and have them, employed by the hospital. But we would like to have the service come in from time to time to be able to serve the populations that we have in our community. Then the rental space, again, can be a good option. So again, there's no one size fits all approach here. So this is something that we need to evaluate carefully as we're deciding to bring specialty providers into our organization and communities. So next, as I mentioned earlier on, telehealth is becoming much more prevalent and much more accepted, I would say, by mainstream patient population. Even Medicare patients, again, we think of some of those populations as the least tech savvy out there since they didn't grow up with it. But certainly this is something that is becoming much more accepted and patients are willing to utilize it. So just a couple definitions here is the originating site. This is where the patient or the patient's physician is located during the encounter itself. Other terms for this, again, think of like a hub and spoke model. This would be the spoke site, the patient site, the remote site, or the rural site. Then we have the distant site, which is where the provider, the specialist, is seeing the patient at a distance and consulting with that patient's provider. So, again, maybe we have the patient come into our clinic and we're consulting with a cardiologist that is, halfway across the state, able to provide the service for our patient. We're not able to, don't have the demand, and maybe from a cost perspective, it's cost prohibitive to hire a cardiologist full-time, but this is an opportunity for us to be able to integrate some specialties within our organization and be able to care for the patient population that, we serve. Some common names for this include the hub site, the specialty site, the physician site, and the referral site. Some of the recent Medicare changes that have occurred is that FQHCs and rural health clinics can serve as a distance site provider for behavioral health and mental health telehealth services. This is something that has been made permanent following COVID-19 pandemic. Medicare patients can receive telehealth services in their home, which is incredibly beneficial and convenient for Medicare patients. And especially if, we operate in rural communities that there may be transportation issues, this is something that can be incredibly beneficial to making sure that those patients are able to receive the behavioral mental health services that they need. Additionally, there are no geographic restrictions for the originating site for behavioral health and telehealth services. One of the requirements, though, is that there's a face-to-face encounter 6 months prior and within a year following this site. But again, say, the patient was into the clinic, 3 months ago, they go on vacation and, something happens, they can do the telehealth visit, that's perfectly okay. They could be many states away, no issues at all. And also rural emergency hospitals that, again, we're starting to hear a little bit more buzz about, are eligible to be the originating site for telehealth services. Additionally, for rural health clinics, there's going to be 2 additional provider types that are going to be able to work in your rural health clinic and see patients as, will be a qualifying visit and be able to receive the all-inclusive rate. These are marriage and family therapists and mental health counselors. So beginning on January 1st of next year, these will be eligible providers in your rural health clinic. And already we are working with organizations that are starting to line up some of these different provider types, getting ready for this rollout at the beginning of the year. So again, additional opportunities to expand different specialty services within, our rural health clinic in that example, to be able to provide additional services that today, at least, we're not able to provide and get reimbursed at our all-inclusive rate. So some additional opportunities are being able to leverage claims data and better understand opportunities for improved patient outcomes. Data is one of those things that we accumulate a ton of, it's underutilized, and it's often very difficult to get out of our EHR system. But this is something that, if we take a look at it, we run our revenue detail reports and we review that on a monthly basis, and we're taking a look at, what services are we seeing grow? We can look at CPT codes and units on a monthly basis. What's growing? What's shrinking? What are some things that we keep hearing patients asking for, but we don't actually offer? So it's using the different data that we have to be able to drive our strategy and our performance improvement efforts. Additionally, we can become a patient-centered medical home. We can use team-based care, improve patient outcomes, and besides just the quality of the service being provided, this is something that we can negotiate with third-party payers and making sure that the clinic is receiving a per member per month payment. So there's kind of this consistent cash flow on a monthly basis for providing and being designated as a patient-centered medical home, that we have this consistent payment coming in on a monthly basis from third-party payers. Additionally, we can look at integrating chronic care management, transitional care management, behavioral health integration or intervention, these different things that we can include within our clinics, that making sure that we're going to improve patient outcomes, they're going to generate incremental revenue, they're going to lead to additional ancillary service utilization. So all good things as we decide to integrate those within our clinics and help continue to grow revenue within our clinics. Can look at integrating and expanding behavioral health services. Again, rural health clinics can be the distant site for behavioral health services, even now in a post-COVID environment. So that's something that we can leverage in our clinics as well. And then, of course, pursuing 340B to drive additional revenue if applicable. So that was the operational considerations. Now we'll talk a little bit about the financial considerations. And really, it's all about how do we optimize revenue. So we've talked a bit about legislative changes that have happened. Those things are going to continue to change, and we're going to need to continue to adapt to optimize revenue and look for different opportunities. So from a clinic perspective, there's really 4 main opportunities that are going to be available to us as critical access hospitals. So the first one is converting eligible practices to a designation that provides the most advantageous reimbursement opportunity. So as I mentioned earlier, maybe we have some freestanding clinics and there's an opportunity to convert that to a rural health clinic, assuming it meets all of the geographic location stipulations. Or maybe that clinic is not in a rural area and it's ineligible to become a rural health clinic, but now with the primary road change, we're able to designate that as a provider-based clinic. So again, all these things are changing all the time. It's really important that we keep our pulse on things to kind of understand, what are we now eligible for based on that most latest legislative change. Next, we can realign practices within a health system and look for different reimbursement advantages. So again, this could be something where critical access hospital is part of a system. At the system level, they have a bunch of practices underneath the mothership, and maybe there's an opportunity to realign those practices underneath critical access hospitals to leverage some reimbursement opportunities. Maybe the main hospital is not eligible for the 340B program, but if we can align those practices, make them provider-based, rural health clinics or provider-based clinics underneath the CA, then they're eligible for 340B in that example. So again, just looking at all the different opportunities and levers that we can pull in order to find additional reimbursement. Third, and again, kind of the premise of this presentation, is finding ways to integrate specialists and specialty practices within a provider-based clinic or rural health clinic to look at alternative reimbursement methodologies. And there will be some examples in the ensuing slides. And then fourth is acquiring independent practices and leveraging provider-based reimbursement and other revenue streams such as 340B. So again, we know that we have independent practices and providers within the communities in which we serve. How do we better align ourselves with them? And maybe one of those ways that we can align ourselves with them is to acquire those practices and convert those to a different designation that's going to be more financially advantageous. Now, again, this may not necessarily lead to a positive return, but it's going to increase the integration within the health system itself whether that's going to be increased referrals for hospital services. And then as we get into future payment models around attributed lives, this is going to be something that will ultimately be beneficial from a reimbursement perspective and or more advantageous for the hospital as a whole as it begins to integrate with a larger health system and is more attractive for those type of systems. So again, this is something that we need to be looking at, I would say, at least on an annual basis to see what type of opportunities exist. So similar to what we covered, this is a graphical representation of some of the different reimbursement options. As I mentioned, a freestanding health clinic all the way on the right, they're not eligible for any of those opportunities. So again, if we can be anything besides that, we generally want to be. Rural health clinic, that has many different opportunities, including 340B. We get a pickup on reimbursement, provider-based clinic as well, eligible for 340B, improved reimbursement, and an FQHC, although it has access to 330 grant and certain malpractice savings, there is a lot of administrative burden that goes along with operating an FQHC. So again, all of these things have pros and cons, but we just need to know what they are and then figure out what works best for our specific situation and how we go about optimizing revenue. So again, this is, excuse me, the rural health clinic rate establishment, kind of how things have changed over the last couple of years. So again, we already touched on a grandfather rural health clinic that based on the fiscal year 20 cost report that will get rolled forward at the Medicare Economic Index. New rural health clinics established after 12/31/2020, those are all going to be paid at the same all-inclusive rate at the upper payment limit. That's going to increase from $100 to $190. And this is something that is going to continue to breed more competition for us in the areas in which we operate. So prior to the legislative change, and even early on, in the last couple of years, maybe even now, that the old rate for a rural health clinic, either under a hospital, again, I'm thinking larger hospital, greater than 50 beds, or an independent rural health clinic, that getting reimbursed at around $85 at that point, and even 100, 113, 126 this year, that from a margin perspective, it wasn't feasible for some larger health systems to really get involved there. Or, again, some of the bigger players like the Walmarts and Amazons and Aetnas that are starting to invade our service areas, there wasn't margin for them to kind of take a more proactive approach of coming into the communities in which we serve in rural. But as that rate continues to increase by 2028 at $190, that's going to be more than $100 greater than what it was prior to the legislative change. And there may be an opportunity there for them to then start looking at clinics and those independent providers that I already mentioned in our service areas and be able to acquire those. And so this is something that we need to be looking at now in order to set ourselves up for the future to try to play defense against any of those other entities that are going to be coming into the service areas in which we operate, and be able to set up our own rural health clinics or our own specialty clinics and be able to kind of protect the service areas in which we currently operate. So again, mentioned the Medicare Economic Index a few times throughout the presentation. We're looking here at the last 10 years or so. At the increase from calendar year 14 to 2023, there was an average of 1.6% increase in the Medicare Economic Index over that period. And what we see is that from looking at the increase in Medicare payments from the fee schedule, that our costs are outpacing that significantly. Even in calendar year 23, where it increased 3.8%, everybody's cost increased greater than 3.8%. So again, some of the things that we've already talked about, we need to keep finding and looking for different opportunities to try to increase and optimize our reimbursement, because we know that from the fee schedule, we're only going to be getting these minor incremental increases that are not going to cover our cost increases. So to close out, a couple real life examples that we've looked at for clinics. So we have a scenario here of, again, looking at designations. And for this one, it's a practice realignment. So this was a hospital, part of a system that they had a bunch of freestanding clinics. They were reimbursed at about $110 on average for Medicare and Medicaid. There were 53,291 annual visits. Again, it's a bunch of different clinics there. And they received about 5.86 million in reimbursement. Then they designated those as provider-based rural health clinics underneath a short-term acute care hospital. And that average reimbursement jumped from $110 to about $190. So that was a pickup in reimbursement of $4.2 million. Now, they also decided to realign these practices underneath a critical access hospital. And again, this was before the Consolidated Appropriations Act, saw a slight pickup in reimbursement from Medicare and Medicaid by about $5 per visit, which equated to about 250 grand. Now, with these clinics being realigned underneath critical access hospital, the impacts on cost-based reimbursement when they pulled overhead from other cost-based services, there was a reduction of about $1.4 million to other cost-based services. However, the critical access hospital being eligible for 340B, where the PPS hospital was not, added an additional $2.6 million there. So the pickup from realigning these practices from the short-term acute care hospital to the critical access hospital was about $1.2 million, or about a $5.7 million pickup from the initial scenario, with those clinics being freestanding clinics. Now, we also look at this even, looking at a post-legislative change. So again, they're provider-based rural health clinics underneath a critical access hospital after the legislative change. So last year, that average reimbursement was $113 per visit. Certainly a significant reduction in reimbursement from the two scenarios prior, when it was before the Consolidated Appropriations Act change. We have the same impact on Medicare and Medicaid reimbursement, same 340B impact. And it is, a large pickup, but it's still positive compared to the freestanding health clinics. But one thing we need to pay attention to is that the entire benefit is derived on these clinics optimizing the 340B program. We have a pickup of $1.3 million compared to freestanding health clinics. We have a benefit of 340B at about double that. So this is something that we want to make sure that even now, post legislative change, that we have all of the other T's crossed and I's dotted, such as 340B, to make sure that this is going to be a fruitful endeavor. Next is looking at provider integration. So this was a critical access hospital that operated a provider-based rural health clinic and a freestanding clinic that had a behavioral health provider. So we see the freestanding clinic was getting reimbursed on average by about $75.64. It's 641 visits, and the reimbursement received was about $48,500. Now we have our provider-based rural health clinic that's getting an all-inclusive rate of $197.24, had about 4,800 visits, and reimbursement was $940,000. And we also see the critical access hospital reimbursement at 340B impact. When we look at the second scenario where we integrate the behavioral health provider into the rural health clinic, we have a reduction in our reimbursement rate, the all-inclusive rate, by about $5.59. And again, as I'd mentioned about our fixed cost and variable cost, that as we add this additional cost and volume of the provider and the visits into the rural health clinic, it dilutes our cost per visit and goes down by about $5.60. But as we add those 641 visits, that's actually going to increase reimbursement by about $96,000 in that example. Now, when we do this integration and we're adding additional cost into the critical access hospital or into the clinic, that's going to draw some of that cost-based reimbursement and overhead away from hospital services to the clinic. And so we see a reduction of about $11,000. But overall, we have a net benefit of integrating this behavioral health provider into the rural health clinic of about $37,000. And I think this is something that is all that much more important now with being subject to the upper payment limit. is that this is an opportunity that if our cost per visit is greater than the upper payment limit, we're able to add behavioral health providers that tend to be a lower cost provider into our RHC, that we're able to ramp up volume, which will help dilute our per visit cost and bring us down ideally below our upper payment limit. And then the next opportunity, again, we talked about this as one of the opportunities, is the practice acquisition. So we have an independent freestanding health clinic, integrating a specialist. We had a provider-based rural health clinic underneath a critical access hospital. So the specialist at the independent clinic was receiving about $81.67 on average from Medicare and Medicaid, 1,752 visits for reimbursement of about $143,000. Similar as the last example, when we add that provider and those visits into the rural health clinic, it's going to dilute the cost-based rate down by about $3.62, but we're driving an extra 1,752 visits into that clinic, which is leading to a pickup in reimbursement of $234,000. So again, we're looking at our critical access hospital, adding that additional provider cost into the rural health clinic is going to pull additional overhead away from the hospital in the way of $34,200. But, when we look at the variance, we have the independent provider being included within the rural health clinic. That was $143,000 of reimbursement, which created $234,000, then reduced by overhead of $34,200 for an overall benefit of about $57,000 to the combined entity. So again, goes to show that, by integrating different specialties and in different ways of doing that within our clinics and our hospital, we're able to increase the net financial benefit of our overall system, which is ultimately the goal and going to allow us to continue to sustain and expand different operations and services into the future. So that is the end of our presentation today. Are there any questions?
I have a question. Can you hear me?
I can.
Hey, my name's Dan. I work in a critical access hospital in Southern Oklahoma in Madill. Earlier in the conversation, you talked about specialty practice. I've been under the assumption that you could not have a specialty clinic like orthopedics or something like that in a rural health clinic. But then it seems like I read something about as long as it's less than half the time that the practice is open as it needs to be, 50%, dedicated to primary care. Can you clarify that?
Yeah, so we're able to integrate specialty services within a rural health clinic. The rural health clinic is designed to be what's called primarily driven. So it needs to be led by primary care. But, again, the regulations stipulate that at least 50% of the rural health clinic time that the clinic is open needs to be primary care time. And so long as less than 50% is specialty, then we're within the regulations, we're able to integrate different specialty providers within our rural health clinic.
And is specialty limited to OB or pediatrics?
OB and peds are actually considered primary care.
Gotcha. And so it could be any other podiatry, orthopedics, cardiac, anything.
Urology, ortho, anything like that.
Thank you so much.
We actually have a clinic in Massachusetts that has a dental practice as part of their RHC. But Zach, do you want to talk a little bit about the freezing of the all-inclusive rate back in 2020 and the setting of the per visit rate for Medicare and Medicaid, and then what that means if you start adding relatively expensive specialty care on top of that frozen rate, where that analysis needs to be carefully done. Basically, back when it was full cost-based reimbursement, uncapped, then the specialty care play was almost a no-brainer, but now it's a little bit more of advanced algebra. But Zach, do you want to talk a little bit more about how we need to carefully treat that reimbursement function now?
Yeah, we need to be more careful about, how and when we're going to include specialists, like the higher cost, like an orthopedic surgeon within our practice. As Greg said, it used to be when it was full on cost-based, we could just kind of include them as much as we could. You know, it was almost a goal really to try to increase our cost-based rate, where now we really want to be seeing them in there only for specific, you know, like follow-up clinic visits and such, to kind of limit their cost, but achieve the higher reimbursement of our all-inclusive rate as a compared to reimbursement received maybe within the hospital. And so when we think about our upper payment limit and our cost per visit, those are two different things. So if we look at our cost report, it will determine what our cost per visit is, dividing our total rural health clinic cost divided by visits. But that may be higher than what our upper payment limit is. So essentially, we're allocating costs that we're not getting any benefit for. You know, we're no longer fully cost-based, so we're not getting that cost per visit. We're getting something less in an upper payment limit. So one of the benefits, and it was in one of the examples, is it was the behavioral health integration, that if we have, you know, a lower cost provider, like a licensed clinical social worker that is an eligible rural health clinic provider, and they're in there seeing, you know, a bunch of patients in our practice, that's going to dilute down our per unit cost, because we're not adding very much cost, but we're adding proportionately more visits. And so we're becoming more efficient, basically, in delivering care within our rural health clinic. And the goal is to dilute that cost per visit below what our upper payment limit is, so that we're receiving our full cost, you know, on a per visit basis in that example. And other things that we can look at as well is how we're allocating cost on the cost report to our rural health clinics. So again, before, it was more advantageous to allocate more cost if we could to the rural health clinic, because we were getting all of that reimbursed by Medicare on a cost basis. Now we need to be more careful of that and make sure that all the costs we're allocating is appropriate. And if there's opportunities to allocate less cost to the rural health clinic, that's something that's going to be more financially beneficial. Hope that answered your question, Greg.
It did. Thanks so much.
For the transition from the current year flex cycle that ends August 31st, and then next year, I don't know if you have it on your docket or your budget for additional RHC webinars like this, but perhaps, based on Daniel's really good question, perhaps we could commit as an extension of this webinar another session in the fall, perhaps, to lay out 2 or 3 scenarios and models and sort of walk through how the numbers interact with one another, because adding specialty care is really important, I think, strategically for clinics and hospitals, but it's also a great way of keeping care local. But with what has happened from the regulations, it is not as straightforward as it once was, and it would be, I guess, counterproductive in a way to fulfill your mission and expand your services and provide great care, only to find out how you are reimbursed is detrimental. And we want to avoid that. We want a win-win-win, not a win-win loss, especially from the CFO's perspective. So I would put out there, Laura, if folks want a more technical case study-based webinar on the impact of specialty integration, that's something we'd be happy to do.
Okay, that sounds great. As Greg was mentioning, yes, our flex year does end at the end of this month. So September 1 is we call it our new year. And so we are in the process of kind of lining up things and planning ahead for the next year. So along those lines, if there are other topics that you guys feel you would really want to hear about, please let me know. All right, real quickly, are there any other questions? All right, I don't see any more. Thank you both, Zach and Greg, for your time today. Thank you for a great presentation, and thank you all for such a great discussion afterwards. If you're catching this recording, if you have any questions at all, please feel free to reach out to me, and everyone have a great rest of your day.
Thanks, Laura, and thank you, everyone.